So today we're going to be talking about IIH, Idiopathic Intracranial Hypertension. It is defined by criteria, which we call the modified Dandy criteria. They had to be modified because Dr. Dandy worked at the Johns Hopkins Hospital in the days before imaging studies. So we've had to account for the improvements in imaging studies. The only thing you got to remember about intracranial hypertension is that it's all about increased intracranial pressure. You can have only symptoms of increased intracranial pressure. And those symptoms are headache, transient visual obscurations lasting seconds at a time, pulse synchronous tinnitus, and blurry vision. You could also have double vision from a non-localizing finding of increased intracranial pressure, a 6th palsy. Rarely patients have a 7th palsy, but your symptoms must be confined to increased ICP. Symptoms are what the patient says. You can only have signs, what we see, of increased intracranial pressure, and those signs are visual loss, big blind spot on the visual field from the papilledema, or a 6th nerve palsy as a non-localizing sign of increased intracranial pressure, and papilledema. Rarely you can have a 7th, but really you're not allowed to have anything else as a sign, only signs of increased intracranial pressure. You have to have scans, and the preferred scan, of course, is MRI with contrast, plus an MR venogram to make sure that it's not venous sinus thrombosis. And we can only have radiographic findings on the MRI and MRV of increased intracranial pressure. Those radiographic signs include flattening of the globe and fluid in the optic nerve sheath, a empty cella, and stenosis, but not thrombosis, of the junction of the transverse and sigmoid venous sinus. If we have signs radiographically of increased intracranial pressure, that supports the diagnosis. And then finally, if the MRI, MRV is negative, we're going to do a spinal tap, and the only thing you're allowed to have on the spinal tap is increased intracranial pressure on opening pressure. You cannot have any abnormality of cerebrospinal fluid protein, glucose, white count. There can't be anything wrong with the CSF constituents. The only thing you're allowed is increased ICP. And so, in summary, to make the diagnosis of idiopathic intracranial hypertension, you must follow the modified Dandy criteria, and it's all about ICP. You can have only symptoms of increased ICP, signs of increased ICP, radiographic signs of increased ICP, and your spinal tap better show increased ICP, but nothing else. And if you've done that, then they have pseudotumor cerebri. Most of the patients, 95% of the cases, are obese young females. Weight loss is the best long-term treatment of the disorder, and a recent randomized controlled clinical trial, which we're not going to cover today, the idiopathic intracranial hypertension trial, showed that acetazolamide and weight loss are the best first-line treatments. And if patients fail, are intolerant of, or non-compliant with maximum medical therapy, weight loss, and the acetazolamide, and if they've had progressive vision loss or intractable headache, then you can have surgery. Our two surgical choices are a shunting procedure, CSF diversion procedure. Our choice normally is stereotactically placed ventriculoperitoneal shunt with a programmable valve, but you could use an LP shunt. Or if it's vision loss as the primary driver for surgery, optic nerve sheath fenestration. Recently, stenting of the stenotic segment in the MR venogram has been proposed, but it is yet to be proven in a randomized controlled clinical manner. However, if there's a pressure gradient and they're not a good surgical candidate, or if they have progression, despite maximum treatment, you could do a stent across that venous sinus. Stay tuned to this channel for whether that's true or not. So I hope you know a little bit more about idiopathic intracranial hypertension.